The moment the tooth comes out, your body already knows something has gone wrong. Not from the pull, from the weeks before it. Picture a barber surgeon's chair in a European market square, somewhere around the 16th century. The crowd is already there. They came for this. Here's what brought you to that chair. The tooth has been dying for months, maybe longer. A molar in the lower left, cracked under years of grit-laden bread. The kind ground from stone mills that left mineral dust in every loaf. The enamel fractured first, then the decay moved inward, slowly, the way rot always moves through wood when the surface breaks. By the time the pulp is involved, you feel it in your jaw, your ear, the socket of your eye. Dental pulp has nowhere to swell. It is sealed inside a rigid shell of dentine and enamel, so the pressure builds inward instead, against nerve tissue that has no tolerance for compression. The pain is not sharp. It is total. It occupies the entire side of your face the way weather occupies a valley. There is no position that relieves it, no sleep that outpaces it, and when the pulp dies completely, the infection doesn't stop. It drains downward through the root tip into the jaw, into the soft tissue beneath the chin, sometimes into the floor of the mouth. A periapical abscess, a Ludwig's angina, a swelling that closes your throat from the inside. People in the ancient and pre-modern world understood none of this vocabulary and understood all of the reality. You go to whoever pulls teeth because the alternative is to keep living inside that pain until it kills you. And it can kill you. It has killed people far younger and stronger than you. So you sit. The setting before the pull matters because it is where your body absorbs what is about to happen. In the market square, there is no private room. There may be a wooden chair or none at all. Just the ground, you kneeling or lying back against the practitioner's body. In a medieval barber surgeon's shop, the records describe patients seated and held, sometimes held by assistants, sometimes simply gripped by the knees of the operator standing over them, straddling the chair, because the force required to move a rooted tooth from a living jaw is not delicate. It is mechanical. Your head needs to be fixed against something, or the pull moves your whole body instead of the tooth. Pain control in this period means almost nothing reliable. Alcohol if you drank enough of it to matter. Henbane, mandrake, opium in preparations of variable concentration and doubtful delivery. The Trotula, a collection of medical texts from the medieval Latin tradition, mentions preparations applied to the gums. John of Ardern, the 14th century English surgeon, documents analgesic compounds. Whether any of it crossed the threshold from discomfort into numbness is a question the sources cannot fully answer. Hedge it honestly. Some operators knew more than others. Some preparations worked better than nothing, and none of them worked the way you need them to. The operator who stands over you is not a dentist. Dentistry as a distinct profession does not exist yet. What exists is a barber surgeon, licensed for bloodletting and minor surgery, a traveling tooth drawer working the market circuit, a village practitioner who learned by watching and by doing. Their knowledge is real. Do not mistake the setting for incompetence. But their tools are what they are. The pelican arrives in European surgical texts around the 15th century. Named for the beak of the bird it superficially resembles, it works on a rotating lever principle. A curved claw is seated over the crown of the tooth, a fulcrum rests against the gum or the neighboring tooth, and the handle is rotated. The force concentrates at the crown. The tooth is supposed to loosen from the socket through rocking pressure and then lift free. In practice, the fulcrum point gouges the soft tissue against which it pivots. The neighboring tooth absorbs part of the load. The gum compresses and tears at the margin. Before the pelican, the dental key, and before that, the simple forceps, a two-handled grip requiring the operator to pull straight out, which works cleanly only when the root is simple, single, and cooperative. The roots are rarely cooperative. Here's what the body registers during the extraction itself. Not pain first. Pressure, an enormous distributed pressure that feels like the jaw itself is being relocated. The periodontal ligament, the tissue anchoring tooth to bone, must be torn around its entire circumference before the tooth moves. This takes force, and force takes time, and during that time, you feel every fiber give way one section at a time. Then the cracking. Not the crack of bone breaking, though that is also possible, but the sound of the socket walls compressing as the tooth displaces through them. It is audible. You hear it inside your own skull before you hear it in the room. Then the bleeding. The socket is deeply vascular and it empties immediately into the space the tooth occupied. The taste is iron and something deeper, something from the bone itself. But what the body wants most in that moment is for the tooth to come out whole. Because if it doesn't, if the root fractures mid-extraction and the broken tip retreats into the socket below the operator's reach, then the procedure has produced a new problem inside the original one. A retained root fragment, embedded, contaminated, sitting in a jaw that is already infected and now additionally traumatized. And that is where it starts to get stranger. The retained root fragment does not announce itself. It sits. For days, sometimes weeks, the jaw closes around it the way water closes around a stone dropped in still water. The swelling begins within hours of the extraction, the tissue above the socket thickening and warming, pulling tight against the bone. This is normal. This is the body doing exactly what it knows how to do, sending fluid and repair cells and inflammation to a site of damage. For a clean extraction with no retained material, no pre-existing infection, a patient in otherwise reasonable health, that process resolves. The socket fills with a blood clot. The clot organizes into granulation tissue. Over weeks, bone fills in from the walls inward. But the socket is rarely clean. The tooth that had to come out was already the center of an infection. The pull does not remove the infection. It removes the tooth. The bacterial colony that spent weeks migrating through the pulp and out through the root tip and into the surrounding bone is still there, distributed through tissue you cannot see and no 16th century operator can reach. The open socket is a direct channel into that territory. A warm, dark, blood-filled tunnel running straight into already compromised bone. Fever arrives between the first and third day in the cases that go wrong, not the low-grade warmth of routine healing. A climbing fever, the jaw and neck swelling outward, lymph nodes along the throat hardening to the touch. The infection spreads the way infection always spreads, through soft tissue planes, following the path of least resistance. Downward into the neck is one path. Across the jaw to the opposite side is another. In the worst cases, the kind that left records because they required further intervention or because they didn't survive to require it, the spread reached the floor of the mouth and the deep spaces of the throat, compressing the airway from outside it. Ludwig's angina, the same condition that had been building before the extraction, now accelerated, now with an open wound feeding it directly. The pain after a failed extraction is different from the pain before it. Before, there was a source, a place you could locate, a tooth you could point to. After, with a retained root and spreading infection, the pain becomes architectural. It occupies the whole jaw, both sides now, the ear, the base of the skull. It does not pulse. It simply is, constant and total and without the mercy of a clear target. This is the grimness. Not the pull itself, but the days that followed it in a world where the word sterilization did not exist and would not exist in any practical sense for another 3 centuries. Every instrument that entered your mouth had been in another mouth. The hands that held your head were not washed in any way that would have mattered. The substances packed into the socket afterward, if anything was packed in at all, might include oil of cloves, wine, vinegar, ash, or nothing. Some of these had real, if limited, effect. Oil of cloves contains eugenol, which has genuine antimicrobial and anesthetic properties, and was known in various preparations across multiple traditions long before anyone could explain why it worked. It is not mythology. It is chemistry that preceded the chemistry by several hundred years. And here is where the reading changes. Because the people sitting in that chair were not confused about their situation. They were not victims of superstition alone. They were making a calculation that the evidence supported, that the tooth was killing them more certainly and more quickly than the extraction would. The untreated abscess does not stabilize. It expands, it tracks, it reaches structures that cannot afford to swell. The extraction, even a brutal one, even one that left a fragment behind, even one that introduced new contamination into old infection, was frequently the better option. Not a good option. The better one. The Persian physician Ibn Sina, writing in the Canon of Medicine in the early 11th century, addressed dental pain and extraction with systematic logic that reads as clinical even now. He categorized the causes of tooth pain, distinguished between treatments aimed at preserving the tooth and those aimed at removing it, and specified that extraction was appropriate when the tooth had become a source of ongoing harm the body could not resolve on its own. He did not recommend extraction as a first response. He recommended it as a considered one, after other interventions had failed, with guidance on how to loosen the tooth first through topical preparations and mechanical manipulation before attempting the pull. The logic is not primitive. It is triage. It is the same reasoning any emergency physician uses today when the question shifts from how do we save this to what causes the least harm now. What Ibn Sina was documenting was not an exception. It was a coherent tradition of dental observation spread across the ancient and medieval world. In Greek texts, in Ayurvedic medicine, in early Chinese medical manuscripts, in the empirical practice of barber surgeons who learned from watching what worked and what killed. The tools were crude, the theory was sometimes wrong, the observation was real. So picture the moment the tooth came free. That specific, particular moment. The pressure releasing all at once, the socket flooding, and then something else. Something quieter. The pain that had been living inside your skull for weeks is not gone yet. The body doesn't work that fast, but the source of it is gone. You are holding a piece of yourself in someone else's hand, and the part of your nervous system that has been screaming for months is reaching towards something it hasn't touched in a long time. Quiet. The first edge of it. Tentative, bleeding, swollen, not yet safe. But there. That person is your ancestor. The same jaw, the same nerve, the same unreasonable relief flooding through a body that had no right to feel relieved yet and felt it anyway. Their mouth was yours. The fear before the chair and the strange peace after it. Those haven't changed. The tooth still comes out. That part was never the question. The question was always whether you survived what came next. And most of them did.